Hi, and welcome to another episode of Cancer Now What's Vodcast by Arizona Center for Cancer Care. My name is Jenny, and in studio with me today is Dr. Erkut Borazanci with HonorHealth's Research Institute and Dr. Steven Sckolnik with Arizona Center for Cancer Care's Radiation Oncology Division. Thanks so much for being here, and looking forward to the conversation. I want to really understand and help our audience understand what it's like for a patient who's been newly diagnosed with pancreatic cancer. Can you help me understand, what are the symptoms that they're having when they first start? What does their primary care doctor notice to maybe trigger a call to you? Dr. B, I'll start with you.
So pancreatic cancer is a tough cancer, first of all, to diagnose. The frustrating part for a lot of people is that a lot of symptoms can mimic other things. So a lot of times that when I sit down with an individual for the first time and get a sense of what their history was before their diagnosis, sometimes it takes months before the actual diagnosis occurs. Pancreatic cancer can present itself as abdominal pain. If you have pancreatic cancer, you could have weight loss. You could have a change in your bowel movements. You could see that your skin color changes. We call that jaundice. You may have some of these things, or you may have all of these things. And it can be frustrating because you may notice this change and go to your doctor and not quite get on the right path for diagnosis.
Oh, I bet that's tough too, because then if you're not getting diagnosed early enough, then you're dealing with something that's harder to treat, I would imagine.
That's correct, because a lot of times with pancreatic cancer, because we don't have a screening program, we don't have a mammogram for pancreatic cancer or a colonoscopy for pancreatic cancer, that diagnosis can be very difficult to make. And so individuals may go through a lot of tests before they actually get diagnosed with pancreatic cancer.
Wow, that's really scary, actually. So once it has been identified as pancreatic cancer, I've heard, localized thrown around, I've heard metastatic thrown around. What's the different types of pancreatic cancer that someone may have, and how do you manage it?
So you can have, when we talk about localized pancreatic cancer, we're talking about the cancer itself is confined or just in the pancreas. And so potentially it can be removed by surgery. When we talk about metastatic pancreatic cancer, we're talking about the cancer has spread beyond the pancreas to other parts of your body.
Okay, and so then the treatment plan obviously would be different depending on the situation.
That's correct.
So for localized pancreatic cancer, what's the first thing that you do? What's the plan?
So for anybody that gets diagnosed with pancreatic cancer, it's important to get a full workup that includes a lot of different types of blood tests. That should include a cancer marker. A lot of times we utilize a cancer marker called CA19-9. And most individuals should be getting a complete body scan of the CT scan of the chest, abdomen, and pelvis. And then in certain situations, they may be also recommended to get a PET scan to look at the whole body.
So let's say we have this hypothetical patient who now has a definitive diagnosis of localized pancreatic cancer. What is the first thing that you do to start figuring out what the treatment plan is going to be?
So the first thing that we do is we see the individual. We do a full history and physical examination, but we do order a bunch of different tests. And the tests include different blood tests, cancer marker tests such as the CA19-9, and then also imaging tests because we want to see the extent of their cancer. Okay. Is it localized or is it other places in the body?
Okay.
And this involves a CAT scan or a PET scan. Part of all this too involves combining all these different doctors together for that individual. So that means the oncologist is involved, the radiation oncologist, the surgical oncologist, the GI doctors, all meeting together to discuss the individual at a tumor board, which we have at HonorHealth on a weekly basis.
Okay, so you all get together and talk about the case, talk about the nuances, because obviously every person is different, right? And together you come up with a plan to present to the patient.
That's correct.
Okay.
And we recognize the fact that for individuals with pancreatic cancer, even if it's localized, there's a high concern that the cancer has already spread beyond the pancreas. And so typically those individuals are recommended to start with chemotherapy, which attacks the pancreas cancer in the pancreas, but if the cancer is anywhere else that we can't even see on a CAT scan.
It'll catch it.
That's right.
So you're acting as though it had spread, even if you can't see that it's spread, because you know it's likely that it will if you don't attack it.
That's correct. So because you hear about that with other cancers. If someone has prostate cancer, they can undergo surgery or radiation therapy only, but pancreatic cancer tends to be aggressive early on.
And how long is the chemo usually last as the first part of the treatment plan?
So chemotherapy varies. Each individual has their own unique journey as far as therapy goes. And that's where the coordination of all these different doctors from all these different areas are so important. And so some individuals may only get a very short course for a couple of months of chemotherapy. Some of them may get 6 months to up to a year before we even talk about surgery for that individual.
Okay, got it. Because you're trying to shrink the cancer to make it as small as possible to give the surgeon the best opportunity to cut it out.
That's one big facet of it. The other big facet of it is that when someone goes through to a surgery, not only do we not want the cancer to come back, we also want to make sure that the surgery is a success for the individual, meaning that when they go through the surgery, all of the cancer is removed from their body.
Okay, got it. So at what point does radiation, and Dr. Sckolnik, where does he pick it up? So the chemo's done, let's assume they needed surgery, or maybe they didn't, I don't know. Where do you come in?
Yeah, so Jenny, I think Dr. Borazanci hit on some really important points with pancreas cancer. And that is that this cancer is unlike any other cancer that we deal with or that we treat. And when you look at the statistics, you might see, well, it's the 10th most frequent or commonly diagnosed cancer in the US, but it's the 3rd most fatal. So there's really this disconnect between the diagnosis and how aggressive this cancer is. So really that's why we approach this in such a different way. And when I sit down with patients after meeting them for the first time, we often draw a flow sheet together, and that's after having met at the tumor board and reviewed their case, and we say, okay, here we are at point A, and based on our results with blood work or with imaging, we might go to point B or C or D, and from there we might add on radiation to your chemotherapy, and then from there, based on the next scan and blood work, we might go to this next point, which may be surgery or maybe more chemotherapy. So I think it really speaks to the complexity of this disease and really the benefit of this kind of teamwork approach of everybody putting their heads together and saying, for a very complex, aggressive disease, what personalized approach can we use to attack it and to target it? Because if there's ever been anything that is not one size fits all, it's pancreatic cancer treatment. You know, we know that the treatment for person A and B and C who might have what looks to be the same kind of cancer on the surface might end up being dramatically different over the first year or 2 or 3 years after their diagnosis.
So that's a great point, Dr. Sckolnik, and I want to ask you kind of a follow-up to that. With patient A, B, and C all being so different, what role does genetics play in getting pancreatic cancer and how you treat it?
I think it's paramount, and that's something that's very important with all of our patients. So from the very beginning, they have genetic screening and genetic counseling done. So we know for a certain percentage of patients, their cancers are going to be primarily driven by a certain inherited genetic mutation. And we know for another group of patients, they might not have an inherited genetic mutation, but rather something that was acquired over their lifetimes. And each of these represents possible targets for our therapy to take advantage of and to personalize this treatment even more. And you think about just 5 years ago, a lot of that information was really a black box to us. We didn't know what was under the surface. You know, it was almost an iceberg phenomena to a certain extent. But now we really know that we have to peel back the layers of the onion and learn more and more about each person's cancer. And I think where we are now, we're only scratching the surface. Over the next 5 years, we're going to be learning more and more and individualizing the therapy so that we can get people to that point where they could have surgery or successfully be cured years down the road.
Anything to add to that in terms of genetics and the importance?
Genetics is very important for pancreatic cancer, both to Dr. Sckolnik's point about the management, and also it's also important as raising the awareness for pancreatic cancer. So individuals are encouraged that we see in the clinic to talk about this with their family. Everybody nowadays with pancreatic cancer does get that genetic testing done. And that, to Dr. Sckolnik's point, does play a big role in their treatment, but also plays a big role in informing their family and to those that may be also at risk for pancreatic cancer. Nowadays, we are testing dozens of genes. In the past, we used to think about genes like BRCA, and we used to think those genes were only associated with breast cancer and ovarian cancer, but we're now realizing that a lot of these genes for other cancers do place one at risk for pancreatic cancer. That's important information, again, for treatment for those individuals too.
Okay, good.
So Jenny, kind of an interesting story that relates to this is we recently had a patient who had been diagnosed 5 years beforehand, and they had had genetic testing done at that time, and there was no abnormality detected on that genetic testing. And then the genetic testing was performed again now 5 years later on their new tumor, and lo and behold, a gene that we didn't know to test for 5 years ago was now identified as being abnormal. So even in just a short span of time, we're identifying new variants and things that in the future will point us in new therapeutic directions, which is the big picture that we really need to think outside the box and be creative with our approaches to this treatment.
And for that specific patient then, because you were able to identify that mutation 5 years later, did that change the way you treated that patient?
It hasn't changed their treatment now because there currently is no therapy to target that mutation, but we think about what's coming down the road 2, 3, 5 years, what therapies are in the pipeline specifically to target that kind of mutation.
Because you know it's a thing and you need to take care of it.
Now that we know it exists, now that we
Okay.
have a target, we know what to aim at. So
Yeah.
it's taking the blindfold off.
Got it.
Yeah, for example, people hear about these DNA repair mutations, BRCA1, BRCA2, and there's now more and more that are being discovered. To Dr. Sckolnik's point, sometimes we don't have the therapy yet developed, but being aware of it's important. For example, in the last couple of years, there's been now a pill approved for individuals with advanced pancreatic cancer to maintain their response to treatment by utilizing a single pill to take every day based upon a BRCA1 or BRCA2 mutation. Even recently, too, we've also been understanding of additional ways to treat these individuals utilizing combined immune therapy treatments. So that genetic result may not yield an immediate therapy today, but to Dr. Sckolnik's point, thanks to clinical trials and ongoing research, we then uncover other ways to attack that cancer down the road.
So that actually brings up a great point also, clinical trials, right? So I know that you're both very heavily involved, you, Dr. B, at the HonorHealth Research Institute, in developing these new treatment methods. What's exciting and on the horizon in pancreatic cancer? What gets you out of bed in the morning to get excited to help more people?
So, pancreatic cancer treatment has undergone a huge change the last 10 years. Before 10 years ago, there was only single agent chemotherapy drugs offered to individuals with localized or advanced pancreatic cancer. And now we have these combination drugs where they combine different chemotherapies together. And so in the past, we used to think the chance of shrinkage was very, very low for people with pancreatic cancer. And now that number has gone up and up and up. Most recently, we've been at the forefront of developing a combination of 3 different chemo drugs that have yielded a 71% shrinkage rate, a deep shrinkage rate for stage 4 pancreatic cancer.
Wow.
And we're building upon that by both the advanced disease and also bringing it to people with localized pancreas cancer with the hope that this will give those individuals a better chance of long-term survival. So what's really encouraging is that there's been a greater awareness, a greater support in the last several years for pancreatic cancer research. And that's how we move the field forward, by understanding more about the biology about this cancer And by targeting it more specifically to those specific mutations or how this cancer works, we're allowed to unlock avenues to offer those better outcomes for people. So it's exciting because at HonorHealth we have 80 clinical trials. Some of them are focused on pancreatic cancer, some of them are focused on certain mutations, as Dr. Sckolnik has mentioned before, that are unique to that individual that we believe may yield better outcomes for that individual.
Great. So how does somebody who is hearing this and get involved? How do they get into a clinical trial? Do they have to be referred in? Like, how does that, or can they just call you and say, I have pancreatic cancer, I want in? Like, how does that work?
They can always call. No matter where.
And stay tuned. I'll give you Dr. Borazanski's cell phone number. Reach him later.
Yeah. So no matter where you live, there's a lot of places to turn to. Thankfully, over the last several years, there's been a lot of advocacy groups for pancreatic cancer. So whether it's Stand Up to Cancer, Pancreas Cancer Action Network, the Sina Magwitz Foundation, among so many others around the country, there's places to turn to look for more answers. And those are avenues to determine, hey, maybe I do have a clinical trial close by to where I live. With that being said, at HonorHealth, we take in people from all around the country if they potentially would like to be evaluated for a clinical trial. But there's a lot of great institutions around the country that are doing great stuff for pancreatic cancer research that may have a great trial for that individual too.
So let me ask you this, and I think about this a lot, right? Because I do hear we've got trials here in Arizona, we've got trials, at Mayo, there's trials at MD Anderson in Texas. At what point, and does this happen where these organizations all kind of get together and say, we're doing a trial together and we can collaborate and it doesn't have to be so siloed. Tell me about that.
So there's a couple of ways that we go about that. So one of the ways is just through conferences. So we have conferences throughout the year where they focus on cancer, and they also can focus on pancreatic cancer specifically. And the purpose of those conferences are to get together and share data, share information. We had a conference a couple months ago where it was focused strictly on pancreatic cancer research. That's one avenue, just to share the information, to publish the information so people can view that and say, that seems like a good idea. Maybe I can offer that for my individuals with pancreatic cancer. The other way to do it is through just working together and collaborating. So frequently we do get together because you can't do this by yourself. Not one institution, not one doctor, or even one group of doctors can do it by themselves. So various collaborations do occur. That can be through these organizations. Stand Up Cancer, Pancreas Cancer Action Network, Sina Magwitz, they've all funded trials where they've encouraged individuals to get together from different institutions to what you said, to get together, share that information, and to look at cancer from a different angle to develop better options for people with cancer. So that's where that comes from, because we not one person can do everything.
So essentially then, people don't necessarily have to get on a plane to get good cancer care or to get the latest clinical trial.
Yeah, I think you make a good point. Previously, people were geographically restricted. Only a certain number of people could have traveled to a place like the Piper Center or to MD Anderson to have a second opinion. But now with the development of telehealth consultation and being able to remotely interact with anybody, we're kind of opening these resources up to a broader swath of people who might not have it in their backyards. And you think about from a larger altruistic point of view, it's really, really great to offer this to as many patients who can benefit from it as possible.
Yeah, and the more patients you offer it to, sounds like the more that we learn about it and can even do better in the future and help even more people. So.
And we frequently reach out to the local oncologists, so we may have individuals that are coming in from out of state, and sometimes it's not the right time for them to be on a clinical trial, but we can also collaborate with their oncologist back home. And what's a great reward to see happen is that sometimes people come in from out of state and they'll say, hey, I've been on this therapy, have you heard about it? And it was a therapy that was developed at our clinic at HonorHealth.
Oh, that's amazing.
So that's great to see that, because that's really what you want to see. You want to see that individual saying, gosh, I've read about that. I really want to offer this for my individual, my patient with pancreatic cancer. So when you see that, that's a huge thing, because that tells you that, again, as we talked about before, it's getting out there. Yeah.
So you said something that kind of sparked me, and I want to ask about, it might not be the right time for someone to be in a clinical trial. Can you expand on that a little bit? Because, I've had family members die not just of, I've had family members pass away from cancer, but I did have a relative pass from pancreatic cancer specifically. And he, the first thing that comes to your mind when you get to where you're kind of grasping at straws is a clinical trial something that we can do? So, I know that it's not always the last stop, right?
Right.
When is a good time to be enrolled in a clinical trial if you're treating for pancreatic cancer?
For pancreatic cancer, while we do have good options that are considered standard of care, it's always a good time to bring that up, whether it's your primary care doctor or your local oncologist that you're seeing, just to ask them. As I mentioned before, there are those advocacy groups out there, so you can look into that as another resource to say, hey, maybe I do have a clinical trial for me. With that being said, there's a variety of reasons why a clinical trial is the best option for an individual at a given time. Sometimes there's trials that are offered for initial diagnosis. We call those frontline trials, where they've never received therapy before, and this may be a combination therapy that builds upon established treatments available for that individual for pancreatic cancer. Some of them are for individuals that have been through the standard of care therapies. So they've went through those frontline, those second line studies and treatments, and they're looking for that other option. So we always encourage that, and if you look at the guidelines for cancer, it's always mentioned as the thing to consider a clinical trial, in addition to those standard options for individuals.
Good. Okay, that's good to know.
Yeah.
And one of the, I think, big misconceptions that patients have in their mind when they come for the first time is they say, well, I'm scared or I'm worried about doing a clinical trial because what if I get no treatment? But I think it's important to emphasize that a clinical trial for cancer care, there's never a placebo. You're always having something in addition to what the standard is, or always taking what the regular treatment would have been, but expanding in addition beyond that. So I think it's a common misconception.
Great point, definitely. Well, thank you guys so much for being here today. I really appreciate the insight. And is there anything that you want to make sure that our audience knows to ask their doctor, or to really make sure that if you had to pick one thing for them to know if they were diagnosed, what would it be?
To me, the biggest thing is just to be aware of pancreatic cancer, to talk to your family about their family history, and to have those discussions. Historically, we really didn't have those discussions at the dinner table, whether it's the Thanksgiving dinner or the Christmas dinner.
My father's a gastroenterologist, so we definitely did, but most people don't. Yes, you're right.
So, and again, to ask those questions and to ask your doctor too, do I need to get genetic testing myself? Do I need to be aware of this cancer diagnosis? But as I mentioned before, the biggest thing is advocacy, is to advocate for yourself, for your loved one, to ask those questions. Is this what we should be doing? Is there anything else out there? Where can I turn to? And there are places to turn to. The last thing I would also say too is that there is hope. There's individuals with pancreatic cancer, despite being told by other people that maybe they only had a few months to live, that they do have a chance to live longer. We've had individuals who have been on treatment through trials or getting standard therapies that have crossed 1 year, 2 year, 3 year, 5 year plus anniversaries. So it's not the same situation as it was 10 years ago. Not every single individual is doing great forever, but we're getting better as far as taking care of these individuals and offering them better options to live longer and longer.
I love that. Love that.
Something I always tell patients when I first meet them is that I want them to build their team, because nobody can do this alone, and a team member isn't just their doctor, but it can be the nurse navigator or a nutritionist or even just a family member or friend who comes with them to their visits. So I think the scary part is facing this, what seems like a daunting journey from the beginning, and you need to know that there's always going to be people there on your side, and everybody who you encounter wants to be there for you. We've all chosen this specialty because we want to work with and support people who are going through their hardest time. So, I think pick your team, and because we really all become family together. We will know you from the very beginning, and we want to shepherd you through this process. So I think that is the big picture, and that really helps patients go through this smoothly.
Well, it sounds like you both have definitely the upper hand when it comes to the empathy piece. And I appreciate that, because it's not always about just the clinical. It's about what you're going through as a human being, and the team there to support you, having your back in the way you need it. So thank you both for your commitment to that. Really appreciated.
Thanks, Sharon.
Thank you.
Thank you so much for being here today. Appreciate it. If you would like more information on pancreatic cancer or either of our physicians here today, you can go to arizonaccc.com or honorhealth.com for more information. Thanks so much.